Akiyama. Matthew is an associate professor of medicine and also a practicing internal medicine doctor and infectious disease doctor at the Albert Einstein College of Medicine at the Bronx, Montefiore Medical Center. And he is famous now for his papers in Lancet, focusing in research on HCV among socio-economically marginalized populations. He has received grants. In fact, they are in my portfolio, K99 and R00, to improve the linkage and testing and in HCV. And he also got the prestigious Avenir Award. He's going to discuss hepatitis C in the criminal legal system using a health system framework to understand challenges to and opportunities for elimination. Take it away, Matthew. Thank you for coming.
Thanks so much, Raul. And it's really such an honor to be on such a distinguished panel. And thanks to John and the Coalition and NIDA for hosting this. So I'll dive right in. Thanks so much for the introduction. I'm going to start with an introduction about just priming HCV in correctional settings, why a health systems framework is being proposed for Hep C elimination efforts, then go into the components of the health systems framework, service delivery in the health workforce, specifically HCV testing, treatment, and linkage to care, health information systems, access to essential medicines and financing, leadership and governance, and then end with some conclusions. So we know that the criminal legal system bears a disproportionate burden of hepatitis C as a result of the interrelationship between high-risk behaviors, drug-related crimes, and incarceration. We've already heard that the prevalence can be upwards of 10 to 20 times the surrounding community. And the fact that this is one of the settings where there's the most stark gradient of prevalence between a community setting and any other setting, with 1 to 2% in the adult population and 10 to 40% in correctional settings. Any talk on correctional settings in the US needs to differentiate jails and prisons. So jails house people who are detained or awaiting trial or serving sentences of less than 1 year. Prisons house, on the other hand, people who are convicted of offenses and serving sentences of greater than 1 year. Jails are characterized by a great degree of churn. People are frequently coming and going. Mean lengths of stay are in the order of 25 days. Median is even shorter. And the population can turn over 12 times in a year. So very dynamic, lots of movement. On the other hand, prisons are static, more static with minimal churn. There are 2.1 million incarcerated people in the United States, but at any given time, 2 to 3 times as many are incarcerated as in prison as there are in jail. But if you consider a community dwelling person, of the 10.6 million jail admissions there are every year, 600,000 of those people will go on to prison, but 10 million will return to the community, giving rise to the term the revolving door, where ongoing risk behaviors can occur, usually higher frequency risk behaviors, but not necessarily higher risk events than the risk behaviors that occur while incarcerated. And then when you couple that with the high rates of recidivism and reincarceration, you see that nearly 1/3 of Americans with HCV spend at least part of the year in a correctional facility, and that the corrections community continuum is really essential for HCV elimination. So we published a paper last year in Lancet Gastroenterology on the use of a health system framework to understand challenges and opportunities for Hep C elimination among people incarcerated in prisons. And part of the reason for that is that correctional settings are among the lowest resourced globally. And clearly there are differentials between high income, middle and lower income countries. But wherever you are, correctional settings typically are lower resourced than the surrounding community. They often function outside the larger healthcare system. There are interdigitations between the community system and the prison and jail systems in terms of in-reach for providers coming in from the community to provide services, as well as transfer of patients from correctional settings to the community for care, but largely they function in parallel. And in that setting, there are equitable standards of healthcare that have been put forward for the last almost half century. The standard minimum rules for the treatment of prisoners issued by the UN in 1957, the landmark Supreme Court ruling of Estelle versus Gamble in 1976, declaring that medical malpractice in correctional settings constitutes cruel and unusual punishment, and then the revamping of the standard minimum rules in 2015 as the Mandela rules. So the building blocks of a health systems framework, as outlined by the WHO a little over a decade ago, are service delivery, the health workforce, health information systems, access to essential medicines, financing, leadership, and governance, with the eye towards improving access, coverage, quality, and safety of healthcare, and the ultimate goals and outputs of improved health, both in level and equity, responsiveness, social and financial risk protection, and improved efficiency. Among people who are incarcerated, this is a domain where we can really make headway on the health equity, which is in dire need. The prison system has been growing for the last 4 decades, leading to selective mass incarceration. If you were a Black man in 2001, you had a 1 in 3 chance of being incarcerated, compared with Latinx 1 in 6, and only 1 in 17 among white men. So vast differentials and vast inequality where we can access people to provide better care. So jumping into service delivery in the health workforce, I'm going to give a case example, which is the New York City jail system. I use this example because it's the one I know the best, where I practice, and there are 35,000 admissions annually, with an average daily population of 7,000 people, and a median length of stay of 10 to 24 days, depending on which age range you're looking at. So this setting, it's a jail setting dynamic, one of the hardest settings where we can provide hepatitis C care as a result of all of this movement and the short lengths of stay. But the jail system affords the power to understand in numbers how the population can be engaged in order to pursue the goals of HCV elimination. So we published a study a couple years ago on the care cascade in the New York City jail system during the DAA era from 2014 to 2017. And in this paper, there was an overall cohort of 120,000 people who were admitted to the jail system in that 3-year period. About a third of them were screened for their HCV, and about 12% of those who were screened had a last HCV RNA that was detectable. Some key features of the cohort: the median length of stay per patient during the cohort time period was 27 days. So truly a rapid turnover cohort. 27 days is not long enough to treat with the standard DAA regimen. There were almost 30,000 patients with at least one stay lasting greater than 120 days. So there was a portion, about a fifth, that were incarcerated in this jail setting long enough to be treated with a full course of DAAs. 961 patients had greater than 10 jail admissions. So this is the revolving door. These were people who were reincarcerated greater than 10 times in the 3-year study period. And in this period, there's also a transition from risk factor and birth cohort-based screening to a universal opt-out approach. So a lot happened in these 3 years. This is an older study from Rhode Island from 2005, and I bring it in to introduce the idea that if we're screening based on risk factor criteria alone, we may miss opportunities to screen HCV positive people. In this study in Rhode Island, they screened a cohort of over 4,000 people, 23% of whom were antibody positive, but among those positives, 65% of males and 44% of females did not report injection drug use at intake. So if we were using injection drug use as a criterion for screening, we would have missed over half of the people coming in who were antibody positive. We, in the jail system in New York, undertook a birth cohort approach toward the end of 2013 into 2014. And I show this figure because on the y-axis, you can see the antibody positive level, which tracks through the figure with a solid line. And the peaks you can see are bimodal. If we only used a birth cohort screening approach, everyone born between 1945 and 65, we'd missed that second spike. And this spike that we saw in 2014 was sort of an early warning signal that there was this transition from opioid painkillers and transition to injection drug use happening in the community among younger people who inject drugs. So prisons and jails can actually function as sentinel warning systems as to what's going on around the surrounding community. We now have, as was mentioned, the universal adult screening recommendation. So we no longer have to parse out criteria. So everyone should be screened, especially in high-risk settings like prisons and jails. Moving on to the latter portions of the cascade, you can see that among those who were HCV RNA positive, about 40% were seen by an HCV clinician. And this seems low as the cascade moves on. It seems like there's a drop-off. But if you remember, there was a 26-day median length of stay. So a lot of people just didn't stay long enough in the jail system to be seen by an HCV clinician. Further drop-offs are noted in terms of starts on HCV treatment, but there was still a fair number of people who were started, 248, 164 had SVR12 labs done, and almost 150 had an SVR confirmed. Some notes on this, in our multivariate regression model, factors that were significantly associated with being seen by an HCV clinician included female sex, HIV co-infection, longer stay. So longer stay did predict being seen by a clinician and the possibility of being started on treatment, and frequent stays. So people who were in the revolving door being reincarcerated, while that's not a desired effect, gave an opportunity to re-engage people in the HCV care cascade to initiate them on treatment. This is a look at the way the treatment was scaled up. And the first thing you notice is there are two different populations that were started on treatment. The first in orange are those who come in from the community on treatment already, which is something that we have to be vigilant and wary of in communities where DAs are being rolled out, to ensure we're screening for that and that we continue people who are started on the community. We don't interrupt their treatment. In the jail system in New York, you can see that from 2014 through 2019, there was an increase in the blue, which are jail-initiated starts. And this required a lot of coordination in terms of identifying people who would be in jail long enough, but also over time, identifying people who may be discharged and coming up with a stable discharge plan in conjunction and in collaboration with their legal representation at times to ensure that we had a good, solid plan for people returning to the community. The jail system allows access to hard to reach populations. I show the figure on the right because you can see with the scale up of DAAs in 2014 and even further through 2015, after that time, there was a drop off in the number of prescriptions as reported in Medicaid data. And in this time period in a large jail system, that number was steadily increasing. So while the easier to treat people were sort of in queue and treated, and harder to reach populations may not have been treated, a jail system provides access to that population and allows you to make headway in those elimination goals. This paper outlines a treatment cohort that was carved out a little bit later and over the same time period, but extending further on. So the numbers are a little larger, but the outcomes are largely the same. But I show it because we partnered with the New York City Department of Health Surveillance Registry in order to understand, after release from incarceration, what the rates of recurrent viremia were like. And we noted that about 16% of individuals who had a HCV viral load checked after achieving SVR had an assessment for recurrent viremia, and 16% were positive for a recurrent viremia rate of 10.6 cases per 100 person years. We think this is indicative of reinfection events, given treatment was being given in the jails under directly observed therapy, and also the intervals at which the recurrent viremia checks were done was long enough to surmise that these were reinfection events. 10.6 cases per 100 person years is higher than many of the cohorts we've seen for reinfection among people who inject drugs. It's not as high as some, but it suggests that people leaving correctional settings have high risk behaviors, which we already know. It's a time of high risk for overdose, and also a high risk time for HCV and HIV transmission. So it's a time where people need really active support. I'm going to jump continents now over to Australia. This is a new study that just came out last year and really is a landmark study in our field, the STOP-C study. You're probably familiar with Australia's elimination efforts that included prisons, and the STOP-C study was situated in 4 prisons in New South Wales. Over the 2014 through 2019 period, they scaled up their HCV treatment under the STOP-C study. Those treatments are in blue. The peach color is the treatments that were people coming in on treatment from the community or initiated through the prison health service. So you see a massive spike in 2017. The numbers fell off somewhat after that. But one of the main take-home point, I think, from this study is that if you track the percent who had positive viral loads coming into the study over time from 2014 all the way through 2019, the community viral load that they were interacting with in the prison population in New South Wales ended up falling over time, suggesting that treatment as prevention in the prison system has an impact in new transmissions, both within the prison system and also as treatment is occurring in the community and people are coming into the prison system, it has an overall effect on of treatment as prevention. So it's the first study to really demonstrate that prisons can be leveraged as settings for treatment as prevention. And if you track out what the predicted trend would have been over time and what the observed trend was in HCV incidence on the y-axis per 100 person years, you can see that in this interrupted time series, there was a significant drop in the incidence through this intervention. Bringing back the idea that this corrections community care cascade is really critical for Hep C elimination, both in correctional settings and also in the transition to the community. In terms of linkage to care, there are a few existing data. It's a challenging time to engage participants in research. There are a handful of studies that have outlined the rates of linkage to care in US settings. Rhode Island and South and North Carolina have published some data using a variety of intervention components and have shown varied linkage rates. We undertook a study in the New York City jail system to examine this, to assess the impact of a transitional care coordination intervention on linkage to Hep C care, and to determine barriers and facilitators to linkage to HCV care. Our coordination intervention included a needs assessment while incarcerated, Hep C education, discharge planning by a jail-based transitional care coordinator, and appointment scheduling. That was all in the jail setting. And in the community, we provided reminder phone calls, appointment accompaniment by a community-based patient navigator after reentry. And immediately what you see in terms of the care cascade associated with the study, of the 100 participants who were enrolled, there was a 84% release from their index incarceration and 31% linked to care. You can see that the rate of reincarceration was actually higher than the rate of linkage, which is obviously an undesired outcome. We did use that opportunity for people who were reincarcerated to attempt to relink them, and there were instances of that happening. But again, this is a period where there's a lot of competing priorities, trying to find subsistence, housing, re-engage with family. There's of course active substance use, attending other medical appointments, not only the hepatitis C appointment. So the linkage rate, only a third linked, and there's also room for retention in terms of treatment initiation, completion, and SVR in this care cascade. And it's something that really needs a lot of work to improve if we're going to achieve HCV elimination in the US. In terms of the factors associated with linkage to care, being on methadone prior to incarceration and feeling supported socially were associated with linkage to care. Drinking alcohol to intoxication before incarceration was negatively associated with linkage. And primary care provision, having a primary care provider prior to incarceration was almost associated with linkage to care, suggesting that a pre-existing engagement with the healthcare system prior to incarceration may create a landing pad after incarceration to go back to where existing care has already been established. So I'm going to touch just very briefly on the more distal elements of the health systems framework. Health information systems are critical. A lot of correctional facilities are still using paper medical records, and it's very difficult to extract data. There's an effort by a team of academics and advocates on hepcorrections.org to outline the hepatitis C national landscape for where opt-out universal screening was being offered. And you can see that the data were only updated through 2017, and they've surely increased somewhat. But at that time, even 3 years into DA therapy, there was a big gap in terms of the states offering Hep C screening and intake. Antibody prevalence, same thing. You can see the black and white line states are ones where Hep C antibody prevalence wasn't readily available, and hepatitis C treatment as well. There's missing data from a lot of states, as well as low treatment uptake as of September 2018. And again, there's been more headway, and I think we'll be hearing from Louisiana and Dr. Irvin on some of the efforts there, which is exciting. In terms of access to essential medicines and financing, we've come a long way. Costs in the correctional healthcare systems previously exceeded the entire correctional healthcare budgets, given the high prevalence of Hep C and the high cost of DAAs. Those costs have been reduced dramatically through a variety of different strategies, 340B pricing, market competition, generics, and the Netflix model. So amazing headway has been made, but still a lot of gains can be made to improve access to DAAs in correctional settings. Lastly, leadership and governance. So Hep C in correctional settings it's a problem that's very dire in the US, but it's a global health problem. There are 2.1 million people incarcerated in US jails and prisons, but there are 10.7 million incarcerated worldwide. We have the highest rate by far here, but there's a very large problem elsewhere too. This figure shows the prevalence of HIV, Hep C, hepatitis B, and active TB in correctional settings across regions worldwide. And by far, the red bars that denote the Hep C prevalence show that Hep C is the most prevalent infectious disease by a long way in most places, except for East and Southern Africa and West and Central Africa, where there's a high endemic prevalence of HIV and Hep B in the community. This figure shows the World Health Organization's assessment in 2019 of national plans or treatment guidelines referencing Hep C in prisons. And they found that the majority of countries did not have plans addressing Hep C in correctional settings in their elimination plans. So again, a lot of global governance headway that needs to be made there. So in conclusion, we need to be systematic about our approach to achieve Hep C elimination in correctional settings. Testing and treatment programs need to be scaled up. Linkage to care is essential, and community partnerships are really critical in developing that. Better surveillance and monitoring is needed. We need innovative pricing strategies that can bend the curve further in reducing drug prices and increasing access. And local, state, national, and global leadership and governance are really required for Hep C elimination on a global scale. With that, I would like to acknowledge John and Lindsay for organizing this great webinar series in general, Dr. Mandler, Wilson Compton, and Nora Volkow for your leadership, and my funders. And with that, I'll open it up to questions if there's time. Thank you so much.
Matthew, I congratulate you for this classic presentation. And before we have some questions from the audience, I have a couple of questions I'd like to pose to you.
Sure.
Your research, for your particular research focus, at least the data that you've shown more on jails, are your plans going to also involve federal prisons? Like, for instance, I saw in the map New Mexico with the federal penitentiary there in Santa Fe, in the network of the electronic system. So what are your plans for the future? Are you tackling that?
Here in New York City, the facility that's closest and the one in the most need of research and treatment provision is our jail system. The federal systems are not as proximal, so we're not as active in the federal program. But there are individuals who are doing that work. I think one of the interest that I have in jails is that challenge associated with the rapid turnover and innovative models of care that we can use, coordination with courts, coordination with lawyers, that sort of team-based approach that can help us understand how to engage better with this very rapidly churning population to get them treated and linked to care.
Thank you. Yeah.
Just to build on Raul's comment, I mean, we have a very diversified correctional system in America with hundreds of state and local prisons and jails. And I was really curious as to what are some lessons learned about how did you engage the system, so to speak, of the jail system in New York to get engage their interest? What motivated them to stay engaged? Allow your research. How did they use your data to develop any particular programs or changes in their health system? What do you think are some of the key drivers to pick the interest of correctional systems and to keep them engaged?
Yeah, no, it's a great question. I mean, we're so lucky in New York City to have really engaged leadership. Leadership has been, renowned in the country for public health initiatives in correctional settings in New York. Also funding. New York City is very well funded to be able to deliver these types of initiatives. So those two are key ingredients. And so I think really when we talk about political will and we talk about access to essential medicines and resources, having those available is really critical, and stuff we need to get on board for our settings that don't have access to as much. One way in which the system was changed by the work that we did, the birth cohort testing that we did really drew glaring evidence that there was a younger population emerging to be screened, tested, and treated for Hep C in the 2014 period, when it was becoming more well recognized about the transition from painkillers to injection drug use. So that the data that we produced on birth cohort screening really helped leverage the universal screening, which happened earlier in the New York City jail system than many other systems across the country.
There are several questions about what were the strategies to decrease cost of treatment? You know, they made reference to the subscription model, which I think we'll be hearing about from Rishi in a moment. But any other strategies that come to mind that you'd like to point out?
This has been a challenge. I think and through economies of scale, we would think that, you know, buying more medications could help drive down prices. And it's more common. I'm not an expert in this area, but in terms of the best price calculation and the impacts that lowering prices has on the Medicaid bottom line, I think the ability to negotiate lower prices could only go so far. So I think that was operative to a certain extent, but the most, I'd say the most important factor was having access to a well-funded system, and especially in the earlier days when DAA prices were much higher than they are now.
Mm-hmm. And then quickly, the testing algorithm that you used, did you use point-of-care testing, or do you use a laboratory-based systems?
So in the cohort that I presented in 2014, there was phlebotomy happening. Rapid point-of-care testing hadn't yet emerged, but in that period from 2014 to 2017, rapid point-of-care antibody testing came online and was then reflexed to viral load. We've been waiting for rapid point-of-care viral load testing, and I think that in the US, it's already very active globally, but I think that will be a game changer when we get it. And especially in a jail setting, to contract those elements of the care cascade from testing, viral load confirmation, and then linkage to care it's so critical, and we need it as soon as possible.
Okay. Then lastly, you have a very high rate of reinfection, which brings to mind what are the access to the harm reduction strategies, clean injection equipment, drug treatment for people in correctional settings in New York.
Yeah, so we've been lucky as well in terms the New York City jail system has one of the oldest methadone programs in a jail system in the country, and people have access to opioid agonist therapy and great access to discharge planning to link to harm reduction, needle and syringe programs in the community. So, you know, that with all of that, we still saw a viremic recurrence rate of 10.6 per 100 person years. So, you know, it's definitely a period where we have a period of concern. But, you know, we've heard said that if we're not treating people who are getting reinfected, we're not treating the right population. We're treating a lot of people and you know, reducing the community viral load by doing so. So there's good connectivity, but we're still seeing reinfection rates that would support further interventions after incarceration.
Thank you so much, Matt. I'll turn it back over to Raul.